Hello, everybody. Welcome to the session number 10 of the World Sepsis Congress on Global Health Threat, Sepsis, Pandemics, and Antimicrobial Resistance. You have joined us on session 10, which is Lessons Learned from the Pandemic to Find Common Infectious Diseases. My name is Detlev Ganten. As you can see in the background, I'm from the Charité in Berlin, and I'm the founder of the World Health Summit. I'm not an infection specialist, so I'm very happy that we have the specialists on the panel. And the structure of this panel is that everybody on the panel will present in about 3 minutes what he thinks is most important from his point of view to contribute to the topic of this panel. And then we have a discussion with the audience. So I encourage you already now to pose your questions or to pose them while you are listening. And then I will see that as a moderator. And then I interfere in the discussion with your questions. I'll be happy to consider all of them if possible. The first speaker is Benedetta Allegranzi. Benedetta is from the WHO Infection Prevention Control Hub in Geneva, World Health Organization headquarters. Benedetta Allegranzi is an infectious disease specialist with diplomas in tropical medicine and hygiene from the University of United Kingdom. She has been teaching at the University of Verona, one of the oldest in Europe and I think around the world. So it's a wonderful university. And she has been around the world, especially also in Burundi, in Malaysia. Now she is a member of the Faculty of Medicine of the University of Geneva. Her specialty is antimicrobial resistance, new guidelines of the IPC for implementation of strategies to prevent sepsis and infectious diseases. And she is currently leading a strategy, developing a strategy for global action plan to monitor a framework for the IPC and to be adopted by the World Health Assembly, which will be in May this year, 24. So, Benedetta, the word is yours.
Thanks a lot, Detlev, for your nice introduction. Good morning, good afternoon, good evening, everybody, wherever you are. Firstly, let me thank very much the Global Sepsis Alliance for making huge efforts to organize this year again this outstanding congress that provides new evidence and helps us renovate our thinking about sepsis every year. Sepsis is a preventable tragedy that affects people, often healthy people, while conducting their life or when receiving healthcare for other diseases. Well-functioning integrated health systems are essential for the success of any intervention to fight against sepsis. A reflection on health systems also comes from recent years when we dramatically experienced that the emergence of new infectious threats can cause disruption of essential health services with consequences to the entire health system and weakening of the capacity to diagnose and treat sepsis adequately. Furthermore, I would like to note that coming through the pandemic over the past few years, member states have reiterated the huge need for infection prevention and control, including the control and management of sepsis. Anyone can be vulnerable to infections, and some are particularly at risk for acquiring infections and developing clinical complications leading to sepsis. The ultimate outcome of a patient with an infection that can potentially evolve to sepsis heavily depends on critical steps from adequate infection prevention measures to early diagnosis and appropriate clinical management and treatment. All these steps require strong and integrated health systems and services, which is the focus of my intervention. Indeed, having all systems building blocks in place is critical for sepsis prevention and management. In particular, integrated service delivery, competent and adequate health workforce, appropriate and best quality medical products, vaccines, and technologies for prevention, diagnosis, and clinical management. And finally, well-functioning and integrated health information systems to support identification, handover, and transfer of patients at risk of or affected by sepsis. The concept of universal health coverage, which is very important to WHO and all members of the United Nations, is at the core of the fight against sepsis for several reasons. Firstly, access to adequate and integrated health services for all is critical to avoid occurrence of sepsis and its fatal consequences, in particular at the primary healthcare settings, which frequently are the entry point for patients with infection, and where sepsis signs and symptoms too often go unnotified. Secondly, the quality dimension of universal health coverage, reflected in the quality of the healthcare services delivered, is essential for adequate sepsis prevention, diagnosis, and management. If attention is not paid to the provision of effective, safe, people-centered care at the points of where people access the health system, then the response to sepsis is set up to fail. Finally, I believe that the concept of integrated service delivery must include strong engagement of community in the planning, delivery, and evaluation of the health services that serve them. Over many years, we heard insightful stories of patients with sepsis where relatives and families' role in identifying signs and symptoms of sepsis has been paramount. The effort to address sepsis must engage and integrate communities as a proactive, systematic activities that creates opportunities for their involvement and builds relationships across all stakeholders. WHO made available many tools and resources and is active in supporting countries in the areas I've mentioned, and therefore I will be pleased to further provide you with details later on about this topic. Thanks a lot for your attention.
Thank you, Benedetta. I have already some comments here, and one of the most important comments at the present time is to the audience. Some of the speakers will show slides, most of them don't. So everybody speaks about 3 to 4 minutes. And so if there are no slides to be seen, that's not a technical error. It's because no slides are going to be presented. In addition to that, for the speakers, perhaps you have an audience from all over the world, from Africa, South America, Asia. So I cannot see how many, but from all parts of the world. So we have a wonderful audience. Welcome to all of you. And we now come to the next speaker. And I encourage again those who listen to send me the questions, and then we'll find an answer for them. So next is, I have to look at the, voila, I have to look at where you are on the screen. Velina Pendolovska. Velina is from the Health Security Unit of the Director General Health and Food Safety Department of the European Commission in Brussels, so-called DG Santé. Mm-hmm. And she has studied politics, actually, at the University of Plymouth in the United Kingdom. She has joined the European Commission very early, when she was even younger than now, year 2009, and worked on diverse files and various parts of the European Commission, mainly in the area of health. And now she is very interested and working on antimicrobial resistance, especially covering the public health threats and aspects of European Union policies on AMR. And some of you may have realized the European Union has just declared a European global health strategy. So the European Union will become a very important member of the international efforts to fight infection and other diseases. Velina.
Thank you very much, Detlev, for this introduction. And also on my turn, good morning, good afternoon, and good evening to everyone who is listening. It's a pleasure and an honor for me to be part of this Sepsis Congress. I have to join you, Detlev, in saying that I'm also not an infectious disease specialist, but it's a privilege to be able to give you a bit more of the insight about what the EU has done. My subject of my intervention was preparing the EU to manage infections and cross-border health threats more effectively. And as was already said by Benedetta just before me, the COVID-19 pandemic, I think we can all agree, has been a massive game changer. I think not only in the health community, I think we or the people who are involved in health, this was clearly, but also I think it was a game changer for everyone else. And in terms of drawing attention to and making it absolutely clear what one virus can do if we have no means to counteract it, if you remember, especially the early days of the pandemic. So as a result of this, in the EU, we undertook important initiatives that were triggered by this pandemic to strengthen what we call our EU health security framework, and that entails the legislation that we have for serious cross-border health threats, how that covers everything in terms of preparedness, surveillance, response to any infectious disease, including antimicrobial resistance. I'm going to come back to this in a minute. We also strengthened the mandates of two of our key agencies in the field. Those are the European Centre for Disease Prevention and Control and the European Medicines Agency, that have played a major role also during the pandemic. And last but not least, very importantly, we created a brand new body that did not exist at EU level. That was the equivalent of the United States BARDA. We call it HERA, the Health Emergency Preparedness and Response Authority, specifically to look into preparedness and availability and the role that medical countermeasures play in the response. So anything from the treatment, you probably recall that there was no treatment against COVID, to vaccines, very important countermeasure, but also everything else, including, if you remember, the very early days when we also had shortages of things like gloves. Benedetta mentioned the very important role of infection prevention and control. I think that's another lesson that we can all learn from the pandemic, how important it became, even to a point of personal infection prevention and control, that people were reminded to wash their hands more often, as you know, as a major basic measure, but still very major, let alone infection prevention and control in hospitals and healthcare settings. I would like to say also that the pandemic drew the attention of other parts of government more generally, in terms of, let's say, finance ministers, hopefully, to the topic of health and the importance of maintaining certain capacities in health for preparedness, for response. And at EU level, that was also the case. And the EU in general, I should say this perhaps to our diverse audience, does not hold much powers as such at EU level when it comes to the policy of health. The prerogative for action remains in the hands of the member states of the European Union, but still we decided to increase rather dramatically the funding that we have at EU level when it comes to health. And this is with the creation of our EU for Health program, which is now over 5 billion euro, I think, altogether. And just to give you an example, in the past, it was, I think, altogether around 400 million. So that's a very sizable increase in the funding that we have for health at EU level. And last but not least, I'm trying to stick to my 3 minutes. There's a lot more I could say, of course, about this. But the topic of AMR, I think, and sepsis and healthcare-associated infections, which is, of course, the topic of this Congress. The COVID-19 I mean, AMR has always been a priority for the EU, and we have had action on AMR already for over 2 decades, and we have the latest EU action plan predating the pandemic from 2017. But all these developments, including at international levels, with now, I think you're all familiar with the ongoing negotiations on the pandemic agreement, we think all of them can be usefully harnessed also to combat AMR and healthcare-associated infections. So I'm very pleased to say that just minutes ago, we have also unveiled our latest policy initiative on antimicrobial resistance. This is comes out together with our proposals for revisions to the EU pharmaceutical legislation, and we are planning to propose to the member states of the European Union that we boost our actions on AMR to have targets on AMR, so we can push and even furthermore our domestic activities on AMR, as well as I already mentioned, on the global front, we are very keen to see AMR as a very strong component of the future pandemic agreement. And as part of that also, strengthen things like stewardship, antimicrobial stewardship, infection prevention and control, and also the search for new antimicrobials, which are very urgently needed. So I think I'll stop here looking at the time. Thank you very much. Happy to take any questions in the discussion.
Okay. Thank you very much, Velina. And we are, of course, very happy to hear that European Union Commission really makes major steps to improve its involvement in health, because indeed it is a national problem. It may not be known all over the world. The health is still at the national level, but you have a medical doctor as a president of the commission, so we are looking forward to further progress. Thank you very much. Next one on the panel is John Adabie Appiah. John is a senior specialist in pediatric intensive care. He is a lecturer at the Teaching Hospital and School of Medicine of the Kwame Nkrumah University of Science and Technology in Kumasi in Ghana. He has been working various parts of Africa, especially also in Cape Town. He is a consultant of the COVID-19 case management at WHO, AFRO. He is a clinical consultant for the Geneva team for management also, and various other activities which are too long to elaborate here as an introduction. He has been very much involved in the Africa Sepsis Alliance. And John is the president of the Pediatric Society of Ghana, and his interest focuses on sepsis and critical care training in resource-limited settings, especially in pediatrics. John, we are listening to your presentation.
Thank you very much. Good morning, good afternoon, good evening to all our listeners. I'd like to thank the organizers of this program for the invitation. And by way of my introduction, I'd like to take a look at the childhood mortality report by UNICEF, last report, which was published recently. And it alluded to dramatic reduction in child and youth mortality over the last 30 years. But then we still have 7.4 million deaths among children, adolescents, and then the youth from preventable and treatable causes. These deaths actually weigh heavily on 2 regions, and these mainly are from resource-limited settings. That's Sub-Saharan Africa and Asia. And if we look at the figures a little bit deeper, 80% of these deaths actually occur in a few countries like Nigeria, India, Pakistan, Democratic Republic of Congo, and Ethiopia. Now, looking at also data from sepsis, we know that almost 50 million people are afflicted with sepsis every year. and out of that, 10 to 11 million of them die. And the same stark reality is that majority of the deaths occur in resource-limited settings. The problem with resource-limited setting is the fact that they are faced with many challenges, which is related to management of infections and then sepsis. And these include patient factors. There are distinct disease conditions, distinct pathophysiology, like HIV, anemia, sickle cell disease, which complicates patients who have infections and also increase their risk to infection. There are also pre-hospital factors, and these include care-seeking behavior of families. And again, these are affected by both cultural and traditional practices, which hinders appropriate early intervention. There's also late identification of sepsis. There's absence of emergency transport services and challenges with referral systems. All these complicate the fact that we don't have sufficient staffing, let alone to talk about specialties in managing patients with sepsis. Sepsis is a very complicated disease when you are to manage. There's also lack of equipment, inability to monitor, challenges with drug availability, antibiotics especially, and fake drugs coming into the system abounds. Not only that, but interventions such as blood transfusions, as we see in patients with severe anemia as a result of malaria, and oxygen is at a premium. We have diagnostic tests. We don't have diagnostic tests to help identify patients with sepsis early. There are weak triage system, and again, referral pathway. Lastly, to talk about access to care. If even these resources are there, patients find it difficult to have access to care. In many places, there's limited access in terms of universal health coverage, and people pay out of their pocket. And this significantly limits the ability to manage patients with sepsis. How does this sound in terms of experience with the COVID pandemic, and how is it familiar with that? In any case, the pandemic has shown us that we are able to confront and implement interventions that can change the direction of undesirable situations. Looking back at what we did successfully should help translate to our approach at managing infections and sepsis. Let me list some of the interventions or approach that I find very useful. These include leadership and coordination. Currently, there's virtually very little leadership across resource-limited settings when it comes to infection and then also especially sepsis management. And as a result, there's a haphazard approach to management even within the same country, even within the same facility. There are challenges, as I made about, there are challenges with diagnostics available at the point of care to identify patients early. We know that early identification, early intervention actually reduces mortality. Access to clinical care and tools for management for sepsis. And most importantly in this area, prevention with vaccines, inadequate and not available in all areas in resource-limited settings. We mustn't forget the fact that we need to engage the community to be able to bring infection and sepsis under control. And lastly, to touch on partnerships that we need to build to strengthen management of sepsis at the point where patients need it most. And I think these and many more are legacies from the pandemic that going forward, we can adapt, and contextualize to resource-limited settings to alter the course of sepsis. Thank you.
Thank you very much, John. Next speaker will be a neighbor of mine, but we never met Wiltrud, did we? So Wiltrud is working at the Charité, at the intensive care unit, and she is specialized in telemedicine. And she uses this methodology to monitor the quality of sepsis interventions and intensive care unit activities. You will tell us details about it. And she's also a member of the German Sepsis Foundation. And so beyond the Charité, she's very much involved in promoting the knowledge quality and also the kind of equipment for intensive care in the region at the Charité, which is necessary, I guess, and of course beyond. Wiltrud, it's your turn.
Yeah, thank you, Detlev, for the very kind introduction. Indeed, we are neighbors. Good day, good morning, good afternoon, good evening to everyone who's listening in. I come to you today actually as a clinician, as an intensivist, and I'm very happy to, on behalf of my whole team here at the Telemedical ICU at the Charité, talk about some of our experience that we've made in the field of telemedicine in intensive care. Before the pandemic, during the pandemic, and now ongoing afterwards. Terminology in the field of e-health, I think, can sometimes be a little bit confusing. So I'm trying to be very clear here. In our case, the terms telemedicine and teleconsultations that I'm going to use, they describe a hospital-based approach that we use, where we, from our department of intensive care, from our telemedical ICU, have built up a network of partners of other intensive care units, initially in Germany and then later on also internationally, who are all connected to us here at what we call the Tele-ICU through a secure technology, including an audio-video connection and a shared patient documentation system that can actually be taken to the bedside on the respective ICUs. And basically what we do every day here is virtually meet with these colleagues in our partner units at the bedside, sometimes for scheduled rounds, sometimes on demand, and we provide consultation, second opinion, and also facilitate other expert consultations with other disciplines. And I have to say, especially with the colleagues from the infectious diseases, we have indeed established a very close collaboration in telemedicine in the meantime, and have become like an actual interdisciplinary team at the Tele-ICU. And this is because indeed a huge portion of the consultations evolve around severe infection, sepsis management, and the rational use of antibiotics, which is a huge topic, regardless of the context, be it in Germany or internationally. The Tele-ICU initially was established way before the COVID-19 pandemic as part of a trial, a national trial investigating the role of telemedicine for, improving the quality of critical care in smaller and medium-sized hospitals in Germany. But when the COVID-19 pandemic hit in 2020, it was actually the Robert Koch Institute, the German Public Health Institute, that asked us to become a partner to them in supporting the clinical management of COVID-19 also in other countries. And so there were new partnerships established in the countries of Uzbekistan, in South Africa, in Montenegro, and actually later on also in Uganda. And yeah, really, this is very short time. So all of our wonderful partnerships, they have all come with valuable lessons. And right now, I just want to point out 3 of the big ones that I think are very important. And this is first, telemedicine, in my view, always needs to be thought as a tool, and as a tool that needs to be designed context specific. And the implementation of telemedicine should always build up from local needs and local setting and local infrastructure. And this goes for the choice of technology, and there's a lot of technology around, as well as for the relevant medical care standards. There just is no one size fits all in telemedicine, as in so many other fields. The next one is, in our experience, telemedicine can be a great tool also for knowledge exchange and also for capacity building. And it can be used in this way also to reach a much wider professional audience, And indeed, in our international partnerships, especially in the international partnerships, we have used telemedicine for basic or sometimes more specialized training in intensive care, and of course also in sepsis management. And also we have conveyed relevant evidence-based information, more specialized trainings, for example, around the rational use of antibiotics, as I said, in almost all settings. That was identified as a big challenge during the pandemic. And the third and last thing is that, and this is a lesson that maybe we especially learned in the Montenegro project in the Balkan region, but we see a lot of potential around this for all of our partnerships. We've found it crucial to put a focus on strengthening the role of the nursing staff in critical care. And we found that telemedicine can actually be an incredible tool for doing that. We always had nurses in our team of experts on our side, and we were always looking also for local champions in the nursing teams of the partners. And we feel it worthwhile to put a continued focus in this for, the continued efforts in the existing partner countries, but also for new projects. Also, and especially with regards to prevention of healthcare-associated infections and early detection of sepsis. So we'll be trying to put a focus on this in the future. So yes, moving forward, all of these and some more lessons are now informing several sustained activities in the partner countries, but also new projects. And yes, I'm very much hoping to maybe at the next World Sepsis Congress, I will be able to report on especially one of our exciting new projects, which will run over the next 5 years in sub-Saharan Africa, and will evaluate the role of telemedicine for capacity building around sepsis in these countries. Thank you.
Thank you very much, Wiltrud. We'll have to meet soon.
Gladly.
Okay, so next speaker will be Louise Thwaites. Louise is a researcher and member of the Emerging Infections Group at CUCU. I didn't have time to look up where CUCU is located. Perhaps you can do that, tell us in your introduction. Now she is an associate professor in the Center of Tropical Medicine, Global Health at the University of Oxford. She's very much interested in various diseases. Also tetanus apparently is one of your focus in research. You have a role in a VITAL project. It's called VITAL, which involves developing new devices, technologies for the use of diagnosis, treatment, and rehabilitation following diseases such as tetanus, sepsis, and dengue fever. You are a consultant of the World Health Organization, a member of the Critical Care Asia network, and many other things. And Louisa, the floor or the screen is yours.
Thank you very much, and hello to everybody wherever you are in the world. Yeah, I'll just give you a tiny bit about my background that wasn't mentioned there, in that I'm working at the Oxford University Clinical Research Unit.
Oh, that is Oku.
Yeah, that's Oku,
I see.
and that's
I
in
thought
Ho Chi Minh.
that was a town in Africa and Asia.
No, it's got this very long name. That's why we shorten it. But we're based in Ho Chi Minh City, but actually work in Hanoi in the north of Vietnam, as well as Nepal and Indonesia. And so I guess that's why I'm here today, just giving some perspectives really from my point of view, mainly as a clinical researcher in that area and in a lower resource setting. John has really described the challenges we have day to day in managing patients with sepsis in these kind of settings. So I thought I'd just offer some reflections really about what went well in COVID and what we could learn from that. So I think what I noticed in COVID was seen as a national problem that had to be dealt with by everybody. Velina mentioned as well that other bits of government suddenly became interested in COVID, and that did involve finance areas, there was a really nice coordinated response. And I think if we're looking at improving outcomes from sepsis, then that's absolutely vital. So in Vietnam, there was some really clear, widespread public health messaging that was really good. Treatment for COVID in hospitals was free. It's been mentioned throughout this Congress, the importance of increasing universal healthcare coverage, and Benedetta's mentioned that at the beginning of this session. And I think, bringing that towards sepsis care is really, really important if we can do that. Prevention and vaccination is important. There was a talk earlier today, I don't know if you saw it, improving outcomes from AMR by improving vaccination coverage. I'm interested in tetanus, but there's a lot of vaccine preventable diseases that cause patients to be hospitalized and given antibiotics which are usually unnecessary. And there were some incredible advances in vaccination programs that happened, and very innovative approaches to vaccination in many countries. And I think if we can incorporate those going forward, that would be a huge advance for sepsis. And then finally, in that kind of high level health informatics and systems there, again mentioned by Benedetta earlier. We had excellent data in COVID. We knew how many cases there were. We knew how many they were hospitalized. And yet I know as part of our Asia Pacific Sepsis Alliance work that we're finding it really hard to say how many cases of sepsis there are in the region. There's the global health burden data, which has been shown throughout this Congress, but we are aware of limitations. So getting really good data and keeping those systems going for sepsis would be really helpful, I think. And then from a clinical trials perspective, that's what I do day to day. We saw some amazing partnerships existing, producing evidence rapidly, but pragmatic studies that could quickly be translated into general guidelines and day-to-day practice, I think was excellent. WHO did a great job coordinating that, and their rapid evidence program, their living guidelines program was really useful for many lower resource settings, but also high resource settings. And keeping those partnerships going, I think would be really helpful. But I know that's difficult. How do we do that? Can we use these platforms to do other studies for diseases that are important? We've been discussing doing it for dengue in our region, because dengue has been a huge problem in South and Southeast Asia this year. But keeping those partnerships and that infrastructure alive, not just for pandemic, but really to look at sepsis more generally, I think would be great. And then my final point is a kind of personal thing, is long-term outcomes from sepsis. I've been interested in rehabilitation and long-term outcomes for a while, but in most low resource settings, it's been very much ignored. That's partly because it needs resources, and the resources are already limited. But I think in many lower resource settings now, the attention, the realization that there is something called long COVID, that people who've survived COVID may have other problems, has been really helpful for us in sepsis, because it means that we can start talking about sepsis in that way as well. So hopefully I'm within my time-ish, and I'll end there. Thank you.
Thank you, Louise. Next and last speaker during the panel will be John Marshall. John is from the Department of Surgery at the University of Toronto, St. Michael's Hospital. He's going to show some slides. I was astonished when the screen changed. He's interested in, in intensive medicine, of course, intensive care unit, sepsis, trauma, innate immune response, and everything involved there has been done a lot on clinical trials, and is a member of a number of organizations, founding chair of the International Forum of Acute Care Trialists, Council of the World Federation of Societies of Intensive Care and Critical Care Medicine, Executive Committee of the International Severe Acute Respiratory Infections Consortium, and many others. John. You're an experienced doctor, and we are looking forward to your talk.
Thanks so much, and greetings from Canada. Hello, everyone. I wanted to make 3 points about the consequences of the pandemic for clinical research. And this is going to follow on from the great talk that Louise just gave. And these 3 points are these. First of all, we've learned over the last 3 years that it's possible to collaborate at grand scale in response to an emergency, and that in doing so, we can identify effective and ineffective treatments very, very rapidly. During the pandemic, close to 9,000 trials have been registered at clinicaltrials.gov. Over 100 different countries have launched clinical trials of COVID-19. And these large consortia of clinical trials have recruited tens of thousands of patients with COVID-19, and really for the first time shown that targeting the host response in an infectious disease can save lives. That's really been the holy grail of sepsis research. Second, we've identified novel models of clinical trial design, and in particular, the platform trial, which allows us to study a disease rather than a single intervention, and therefore is infinitely more efficient in its capacity to generate new knowledge. Platform trials also offer the opportunity for patients to be preferentially randomized to interventions that seem to be doing better. And so platform trials really, in the future, hold the promise of merging research with quality improvement and benefiting patients in the process of understanding diseases. And then finally, I think probably the most important lesson going forward is that much as we've accomplished some things that just have never been accomplished before by the global research community, it's also revealed the fault lines in that endeavor. And even if you look at the poster child for research during COVID-19, the NIHR in the United Kingdom, it has been noted that only a small percentage of hospitalized patients were actually recruited to trials in COVID-19. In Canada, we recruited only 2.4% of ICU patients to the REMAP-CAP trial. And so perhaps the most enduring lesson of the pandemic is how much better we can do in the future if we learn to work together and to leverage some of the knowledge that we've gained during the pandemic. So I think the pandemic has really opened a door, given us a glimpse of how we can change the clinical trial enterprise in the future, and how we can better integrate clinical research with the processes of care. Thanks very much.
Okay, thank you, John. Now, we have many listeners, as I mentioned. All of them send their regards, especially John from Cape Town. You seem to be extremely popular there. There's several special greetings for you. There's one comment and one related suggestion, and that is how to choose antibiotics. And then there is a, let me see where that is, there's so many. Comment, laboratory management is very important. In particular, the recently validated UCAST, rapid antibiotic resistance test, can be economically used in many laboratories in the antibiotic management of sepsis. So perhaps you can, one of you, raise your hand or just start talking. How to choose an antibiotic was the question. And then is anybody of you knowing the UCAST rapid test for the diagnostic of sepsis? How to choose an antibiotic?
I'll kick it off if you want. I mean, I think the selection of antibiotics is very much dependent on 2 factors: the likely infecting organism, which can often be estimated from the clinical presentation, and the resistance profile in the area that you're treating the patient. So I think it's hard to generalize the choice of an antibiotic for sepsis, because sepsis is caused by such a diverse variety of microorganisms. But I think about what the likely pathogen is and the resistance profile in the area that you are.
My question would be what a resistance profile and antibiogram and all that, be feasible in all low-income and low resources countries, or how is the situation there? John, Adabie, you probably, yes, you have raised your hand already.
Thank you very much for the question. Yeah, choosing antibiotics to manage patients in resource-limited settings very difficult. Many places, it's not availability of cultures to identify even organisms to treat, availability of identifying resistance pattern. It's a whole different ball game on its own in many places in the continent. And I agree with everything John said. I'm not familiar with the UCAS system, but it all also boils down to making it available. If it's that simple, making it available to resource-limited settings, and that the clinician at the primary care level, the healthcare worker at the primary care level, how accessible is this available to such a person to manage patients? If we look at malaria, for instance, in many places, we have one antimicrobial or two antimicrobials that we have recommended to be used, looking at the resistance pattern across the country. This is not the case with sepsis, where we see variable organisms causing it, from viruses, parasites, and then bacteria, and even tuberculosis, and so on and so forth. So it's a huge challenge, and this is where again, coming in, just like we have discussed, how can we tap into the pandemic, our response to the pandemic, how we work together to be able to generate our ability to identify COVID early, to implement lateral flow tests that can help you identify. So these are challenges that we face in the resource-limited settings. And to be able to do this, we definitely need to move in that direction. And here, just like John said, we need a leader. We need leadership. John and Louise said, we need leadership. We need WHO to come in and provide that leadership. If you look at resource-limited settings or low-middle income countries, we tend to rely on guidelines and recommendations from WHO. This is what our national governments understand, our policymakers rely on. So if there is there's guidelines from WHO, from our recognized bodies, it makes it easier for us to work with individual recommendations from different organizations. Thank you, Nova.
So that is a real dilemma. I mean, if you don't have the proper diagnosis and specific diagnosis, then you cannot use a specific antibiotic. This, of course, then leads to everything afterwards, which we are confronted with creating resistance and all that kind of thing. So, the textbook is good and fine. In practice, it's so difficult. Benedetta, WHO is the solution of everything.
Yes, indeed. Thank you. I wish it was true that we are such a superpower. So I just wanted to mention a couple of points from my perspective. The first one is really vis-a-vis to the question how you select antibiotics. I would like to say that, in my opinion, there is another question to be asked, which is whether an antibiotic or an antimicrobial is needed, because, of course, we are talking about patients with sepsis. Of course, these are very critical patients, so it's clear that in many cases an antibiotic will be needed, but not always. And this is why having knowledge about the most likely pathogens according to the age, according to the type of patient, and to the type of infection is critical. So this was the first comment I wanted to make. Then, as a follow-up of John Marshall's point, and also John Appiah as well, about the challenge is to make the diagnosis, the etiology diagnosis in low middle income countries. As you know, WHO since many years has promoted GLASS and has promoted really the concept of strengthening laboratory-based pathogen detection, including quality and including AMR patterns. There have been major progresses over years in the coverage of this network, of this approach, but of course we are far from having all countries on board with GLASS. What I would like to say, though, is that low middle income countries, including African countries, numbers of participation in GLASS has increased over time. And so it means that thanks to many efforts by many stakeholders, certainly not only WHO, but donors, many stakeholders, this is improving. In my opinion, one critical point to make this work is dissemination of data and use of data. Because in my opinion, even in high-income countries, and I'm thinking of, the huge data availability exists in Europe, for example, thanks to the European CDC. Still, I'm not sure that even in high-income countries, the data that are available are used properly. And when I'm thinking of an African country, if this African country is part of GLASS, which means that there is at least one reference lab in the country, collecting data, having data on the principal patterns of antimicrobial resistance, for example, in key pathogens. Are these data disseminated to the most important hospitals in the country? Because still, if these hospitals don't have lab capacity, but if they knew at least the most prevalent pathogens and their antimicrobial resistance patterns in one reference hospital, this would be a starting point, I believe. So it's not only about capacity, which is lacking, but it's also about how you use the data, how the ministry is able to disseminate the data and help healthcare providers to interpret the data and use them. So these are the main comments I wanted to make on this topic, and I think this discussion is really very important.
Okay. Velina, you want to add something?
Yes, I think I raised my hand for something else, and there were so many interesting things mentioned. So
okay, go ahead.
I'll try to.
Velina.
Thank you, Detlev. But I'll try to, I don't know, structure my thoughts here, because there were so many important things. I'm approaching it a bit from, not so much from a clinical perspective, how should we prescribe antibiotics, but rather from the sort of public health system perspective. I'll say this: we have at EU level guidelines on the prudent use of antimicrobials. What we don't have at EU level, at least not EU guidelines, is on treatment guidelines for specific major syndromes or major diseases. There is thinking to go into that direction in case that would be helpful. But we also notice another phenomenon, that despite the guidelines, there is sometimes lack of adherence to the guidelines. And this is, I think, what Benedetta mentioned just now, very important, this feedback loop back to the prescribers, back to the doctors, and the labs play a very important role there. Microbiologists, all of the players in the whole system, about their prescription practices, that is not taking place. Maybe in some EU member states, but not everywhere. I'm talking about the EU. I can only imagine what could be in other parts of the world. So guidelines is one thing. The other thing, education of healthcare professionals, continuous education. because these pathogens, they change, resistance appears all the time. And it's perhaps, especially for primary care professionals like GPs, I don't know how often they get to refresh their knowledge about antimicrobial resistance, how much time they may have. And another point that was mentioned, rapid diagnostics. I think that is key, and we keep talking about this and funding research about this under the EU research programs. And then there's the other side of the coin, are those diagnostics reimbursed by national healthcare systems? If they aren't, then the doctors are not going to use them. But it's important to push somebody. I think Louise mentioned vaccination in terms of prevention. I mean, when I look at the major pathogens that we know are showing resistance, and I'm guessing are also contributing to sepsis in the EU, we are talking E. coli, Klebsiella, MRSA. We don't have vaccines against these. So it would be, if I would have to put, a list of top vaccines that we hope could be developed, I would put these. We know that the burden of AMR in the EU is bigger than the burden of influenza, TB, and HIV combined. So why wouldn't we invest in this? At the same time, the burden of healthcare-associated infection is even higher in the EU. The AMR is estimated at least 35,000 deaths per year and growing. And healthcare-associated infection, which include things like bloodstream infections, but also pneumonia, urinary tract infection, over 9 million per year. So all of these elements, I'm looking at them from the perspective of prevention, preparedness, and response to these bigger threats. So these are my thoughts at the moment. Thank you.
Okay, thank you. I have a couple of questions here, and one is from Laura from Argentina. Great presentations. Thank you very much. My question is whether the platform trial concept could be used to study post-sepsis syndrome. In the meantime, while you think about it, there's also a message that the UCAST trial, which I mentioned in one of the other questions, is not available in low and middle income countries. But there seems to be another cheaper test available. So the question from Argentina. Louise.
Hi, thanks. I'm sure there's a few people want to comment on this. I'm sure John will too. I'm very much in favor of collaborative trials, so I'd like to say yes to start off with. Why not? I think it would be really valuable to have more data on this and to look at interventions that might help with that. I think a practical thing, if we're thinking about these global trials, I speak as someone who's participating in the recovery trial, is that in lower resource settings, getting that long-term data after patients leave hospital is much, much harder. And that's probably partly why these things have been ignored in the past. But with recovery, we are managing at least to telephone patients after they've been discharged and get some of these longer-term outcomes. So yes, why not? And I think, getting involved with the collaborations and the groups and looking at these interventions would be really something that we should be doing in the future.
Okay, John?
I completely agree with Louise's comments. Definitely, yes, it can be applied. The differentiating factor with platform trials is not so much the trial itself, it's in the initial design of the trial and how you focus on a disease and how you make decisions about randomization. So once the trial is going, it's very much just like a conventional clinical trial. The challenges obviously are implementing a trial in the ambulatory setting, the post-hospital setting, but that's being done actually now with several platform trials, and seems to be working out quite well. So I do think that this is a model of research that has tremendous possibilities associated with it because of the fact that it's much more readily integrated into clinical practice. We, for example, in REMAP-CAP are using registries to randomize patients to the trial in Southeast Asia. And so that is another opportunity that arises there. So an enthusiastic yes.
Okay, Thank you. There's a question. We have most antibiotic resistance for the latest antibiotics. How to tackle this problem? You have an answer? Or do we need somebody from the pharmaceutical industry to give an answer? Perhaps I'm a pharmacologist by training, or Velina, you want to answer? I can say that, from my experience with the pharmaceutical industry, of course, developing antibiotics is not an easy task. And to develop very specific antibiotics for very specific diseases and be sure that they have a sufficient spectrum for the cases occurring is a big problem. And many companies resign from this research, which is a real big problem. And one of the answers should be, of course, that good antibiotics and good diagnostic is being done so that you can use selectively those existing antibiotics which work. And if you go with broad spectrum antibiotics, then of course you create resistance and then it's a never-ending story. So I think this indicates a real problem between proper treatment, specific treatment, and providing new antibiotics. And of course, the bacteria and all the infectious agents, they mutate relatively fast. So there are new organisms coming up all the time. So yes, Velina. The European Commission has a solution.
Has a plan, yes. No, I mean, you're absolutely right. This is I would say not the $1 million question, it's the $1 billion question. How do we get a new class of antibiotics which could indeed cost an enormous amount of money in terms of research and then clinical trials? And that hasn't happened in the last 30 years, to my knowledge. A new class. We have had new antibiotics, but they're essentially tweaking the old ones and trying to, outpace the issue, which is the antimicrobial resistance. We are, what I just mentioned today, we are unveiling a revision of the EU pharmaceutical legislation, and we are proposing some mechanisms of how this could be done through transferable exclusivity vouchers. I'm not going to go in depth exactly what that is. You can look it up. And thinking of other methods, there are different schemes that are also being developed globally in other parts of the world as well to look how we can overcome this problem. I will just basically say, indeed, the other side of the coin, so that we don't end up with new antibiotic that is very costly and only, 5-10 years down the line, go back to square one with resistance. The other side of the coin is what you said, Detlev, that absolutely prudent use. Once we have it out there, it will have to be used extremely sparingly and only for very dire and serious cases. Otherwise, we run the risk to be back, as I said, back to square one. Thank you.
Can I ask you a question, which may be out of place, but you are the specialist. I've been the founder of the Max Delbrück Center for Molecular Medicine here in Berlin. And Max Delbrück has developed phage genetics. And these phages are now being used and can be very specific for specific bacteria, especially. So is treatment of infections with phages, I know it's being done, but has this penetrated already school medicine and clinical practice? Wiltrud at the Charité. I mean, in Berlin, they should be follow the ideas of Max Delbrück, who was a Berliner.
Definitely. But, as you know, implementation of research into practice takes a long time, much too long time. We're not doing that at the moment. We are still, even in trial settings, are still busy with, other aspects at the moment. And so far, it hasn't reached our intensive care.
Anybody else on the panel who knows about it, the progress there? My information is that in Eastern European countries, it's being done, but I have no information how well it's being done. Okay.
Detlev, maybe I can only comment on this. This is one of the FASH therapies, one option for what we call alternatives to antibiotics. And it is something that we would like to look into, if I'm not wrong, under our research program. Yes, to my knowledge, it's more in the area of research at the moment. I'm not sure how much it is in clinical practice in the EU, but this is one option, and many others as well as prevention, what I mentioned, vaccination, and looking a little bit more into the question of the transmission of resistance, and how resistance, especially in the environment, how it develops, because we seem to, of course, all have this understanding that the main driver of resistance is overuse of antibiotics, but there are signals. I'll mention one about the role of antidepressants on the development of resistance, which is perhaps, I don't know how many are familiar with this. And then, as I said, the environment, I think, is well recognized as a bit an underexplored area. We don't know exactly what happens there. We tend to have more information on humans and animals and the link between humans and animals, but the whole One Health spectrum needs to be even more looked at. Thank you.
And there is another comment here which relates to what we have been discussing, and that is antibiotic results are available after 48 hours in conventional routine laboratories. Microorganism diagnosis can be made quickly with new generation sequencing systems and rapid diagnosis methods, but it is not cost effective. However, the most common microorganism in blood samples will be produced by RAST, I don't know what that means, which can be of rapid sequencing probably, which can be of great benefit to the clinic, thanks. So rapid sequencing of the microorganism, is that something which probably not available in low resources countries, but is it being done frequently?
Perhaps I'll just perhaps offer a comment, because I work in quite a unique environment where we can do some of these. We do a lot of these, really innovative diagnostics and tests, but in the context of a low resource setting. And we often get asked, why are you doing that? Because that's not affordable for routine use in hospitals. And the answer really is, well, firstly, it might not be now, but it certainly could become so as the technologies evolve. But also, I think what we do try and do alongside it is the health economics of why we're doing it. So yes, the test is expensive, but actually antibiotics in our setting are very expensive because we nearly always need to use carbapenems, which are very expensive. The costs of prolonged hospitalization are high. And of course, our patients are often paying out of pocket themselves. There's often very high indirect medical costs for the patients involved. So I think there is a rationale for doing these within reason in a lot of settings. And I think accompanying by good health economy and really understanding the impact beyond just quickly getting a result is really important.
Mm-hmm. Okay, so our colleague from somewhere in the world is just telling us that the RAS is the abbreviation, as we mentioned, Rapid Antibiotic Test Systems. Okay, John.
Thank you very much. I would like to dovetail onto what Louise just highlighted. And in fact, it's very important to realize that on the face value, if we look at the investigation, identifying pathogens to treat, looks like it's expensive. But if in my practice, it's much more cheaper than really getting down to identify the organism that you are treating. And I see that frequently where in practice, we chop and change antibiotics more frequently without really identifying knowing what we are treating. I can cite examples upon examples, some medication that's quite expensive, high-end we just do that and eventually get to the point where these expensive drugs are also not working. Then what do? That's when we take a step back. But if we are taking the step to do the right, proper investigation, it would have been much more cheaper in that context than assuming that all initial attempts to identify the organism and treat appropriately actually is the headache. No, it is not. We need to take that step and then moving forward. The other thing also I want to talk about the antibiotic use is antibiotic stewardship. We need to take that very seriously in our practice. Without that, we are going to add to what the rest have spoken about, and we are part of the problem. We need to understand when to initiate, when to change, when to stop, and be confident enough to be able to say, this is not helping, let me stop it at the right time. Thank you.
Then there's another question. Many low and middle income countries are involved with global PPS and WHO PPS to obtain data that helps in driving for AMR response through AMS implementation. Benedetta, you have an answer to this?
Well, I'm not sure it's a question. Is it a question about which countries?
Or a comment, the comment?
Well, the colleague who made this comment was mentioning the fact that WHO is currently proposing a point prevalence study about antimicrobial resistance in countries, which would be really important to gather more data on the global perspective and also regional perspective of antimicrobial resistance of some key pathogens which are considered priority. So thank you for mentioning that. It's a great opportunity for me to actually encourage any country to participate. This would be very useful for the world and for your own country. I also wanted to mention another point which I forgot earlier. WHO issued a few years ago a very useful toolkit for antimicrobial stewardship in low resource settings. So that is really something that is adapted to the challenges that are experienced in low resource settings in order to develop antimicrobial stewardship guidance and implement it. It's also based on multidisciplinary approaches and has suggestions for additional tools to be used. So I encourage you to look for this document it's a manual for antimicrobial stewardship for low resource settings.
Okay, thank you very much. There's some discussion on acupuncture before or after acupuncture. This hasn't been mentioned so far, perhaps infections of the nervous system. Or would there be a comment on when you use acupuncture and what kind of diseases are the most relevant, perhaps in low resources countries? Or John, is it usually blood samples? How frequent do you have infections? How frequent are the infections, and how frequently do you acupuncture in sepsis? But that's the meaning of the question.
Right. Either way, I don't have any experience in this area. I don't see patients who come in either having gone through acupuncture therapy, and we've also not used acupuncture to treat any patient with sepsis. So I don't have any experience. We don't need to comment on this. I don't know if any other colleagues will.
Okay. Then there's a comment: in Africa, the resources for such sophisticated diagnostics and machine and laboratory investigations are limited and located only in the capital. Therefore, most sepsis cases are treated based on symptoms. That's probably a statement from the practice. And my question then would be to Velina. You have several billion, and you're proud of it, correctly so, health program at the European Union. I'm sure this money does not go to Berlin or London or Oxford or Paris, but goes to low-resource countries, does it?
No, this is actually the health program is for the EU actions, funding EU actions. I would just like to maybe stress that it is for all health-related activities. So that includes funding our cancer, beating cancer plan as well, which is a major part of it. This is for activities in the EU. For funding outside of the EU, we have other instruments on that, and perhaps they're even bigger. I'm not super familiar with them, I must admit, where we support the global health strategy of the European Union. So these are, depending on the countries of the world, there are different instruments. But the EU for Health is for the EU member states, plus the associated countries, to my knowledge, that's Norway, Iceland, and Ukraine now.
Well, then this deserves a special comment from the moderator. It's common knowledge that most of the money from the rich countries really stays in the rich countries, even for global health activities, training, and not enough money goes to low-resource countries. But even, and this is a kind of a suggestion for Wiltrud, for many others. I mean, even if you develop new methodologies like telemedicine, which also is a training method, as you see, as you said, and which is important, of course you can have partners all over the world, especially in telemedicine, and train them and get them involved in European programs, which many do. I mean, this is not a new invention, but it's not done sufficiently probably to really have low and middle income countries participate in the further development of progress in medicine. So my specific question would be to all of you actually who are relatively or completely spoiled and well-funded specialists, how much interaction is there between your laboratories and your colleagues with countries in low and middle income of low resource? Wiltrud, you first. You said you have a training program.
Yeah, I can maybe talk a little about the sustainment or the strategies for sustainability in the projects that we started. And as I said, the international cooperations were started in the time of the COVID-19 pandemic, and there was funding for these kinds of corporations. And yes, now with the situation has changed, and actually a lot of that funding has gone away with the subsiding pandemic and the different situation in Europe and other priorities also in Europe with the war in Ukraine. And we're looking at the challenge of sustaining these programs in the respective countries, and what one of the solutions is, and this also is in connection with the point that there have been, there's a lot of success in partnering internationally in these countries, but I think as a sustainability strategy, actually the local ownership of these programs and the local taking over of the concept and the structures, maybe even scaling it up in their countries and in the regions, as we're trying to do, for example, in the Balkan region or in Central Asia, in Uzbekistan, is the way to go forward. And as for funding, yes, that's difficult, especially when you then go to bigger network undertakings, like I just mentioned, in the region of Central Asia. That's where it starts, where we have to look for sources, definitely.
Thank you. Velina and well, colleagues, all of you. This panel is not just for teaching those who listen, but in a good panel, the panelists also learn. And I think it is important to really consider, and one of the learnings of this discussion, but this is not completely new, it has been said in many other discussions, it is so important if we want to improve health around the world, especially infectious diseases. There it's very plausible because infectious diseases know no border, okay? Cancer is different. That's not infectious, but you know, viruses and bacteria cross borders, as we know. So involving other countries in all these developments, both technologically, but also with respect to training and providing the facilities, you know, at the place where needed, I think is important, which we have to consider, and all of you are in important positions and being able to counsel grant givers and politics and whoever has to decide. I think that's an important point. And I know from, you know, my own experience, once you do that, it's so rewarding. And the young people are, especially the young, you know, the old professors, you know, kind of sit at their chair and well, they do. I'm sorry, I'm not qualifying that, but young people are especially idealistic, and they're not bound to profession and daily duties and so on. And they like to do that. They like to go abroad and learn together, and it's learning on both sides. So I think this is a point for global health, which has to be, and I'm sure Benedetta, well, your hand is up. That's, of course, the WHO cannot do that, but you can stimulate this type of attitude, collaboration between low and middle income countries and high income countries. Really have to collaborate, not just by training, but by providing facilities, and then kind of get the ball rolling and really bring global health forward. Benedetta.
Thanks a lot. Of course, I couldn't agree more. As we all know, all our activity is oriented towards low resource settings, and in particular low middle income countries. In particular, related to this session, and also what was the focus of my presentation, I really wanted to remind everyone that there are strong data, which we included also in our global report on sepsis 2 years ago, that show that there is clearly significantly higher sepsis frequency and mortality in low middle income countries. And thinking of the focus of my presentation, where I tried to explain how much integrated health systems are important to tackle sepsis, we can also say that data related to the health systems building blocks that are available, again, highlight weaker and less integrated health systems and gaps in essential health services and infection prevention and control programs in these countries. So there are very clear reasons for prioritizing these countries and settings, clear evidence which can be used also to convince to convince policymakers, to convince donors to focus on this. However, saying this is easy. Working on this is more complex. And I think we need to approach this topic being humble and knowing that there is a lot to learn from these settings, and that any proposal, any intervention we make in this direction must be adapted according to the local reality of these settings. And there are many lessons to be learned, and research should be encouraged also, including qualitative research, to understand what are the barriers, what are the facilitating factors for implementation of solutions to prevent and manage sepsis in low-middle-income countries.
Okay, thank you. Velina?
Sorry, I know we're running out of time. Just wanted to clarify. You mentioned 5 billion for the EU for Health program. I found the other instrument. It's called Global Europe, and it's 79.5 billion euro. So it's a lot more, and of which 29.8 billion for Sub-Saharan Africa. I just wanted to give you the figures to give you a sense of what we're talking about here.
Leave us your phone number and we'll call you up.
on the radar. Thank you.
Okay, thank you. And everybody listening has, I think with great pleasure, has heard these figures. No, I think it's fantastic what Europe is doing in the health area, and this is has not been so generous in the past. So thank you very much, and best regards to the Commission and the President. Indeed, the time is up, and I have one comment here. Thank you very much to the whole panel. Hope you will come up with some solutions for low and middle income countries, and especially for Africa. So I think this is almost a very nice conclusion. And I indeed thank you very much. I learned a lot, and I think it was a very lively discussion. I'm very happy that we had so many questions from outside and confident answers. We have not solved all the problems. Antimicrobial resistance and sepsis remains a big problem, diagnostics and treatment. So it was very good that we had this international symposium. Thank you to all the sponsors, and thank you to those who organized the meeting. And I can't wish you safe return home, but go back to work would be but it's very important and wonderful work, and try to be as effective as you have been in the past and try to improve global health together. Thank you very much, and hope to see you in person soon somewhere. Wiltrud, we'll meet this afternoon.
Thank you very much, everybody.
Okay.
Bye-bye.
Mm-hmm.
Bye-bye.
Thank you. Bye-bye.
Bye-bye.